Yeah, my name is Trevor Hunter. I'm the primary care pharmacist in the Northwest, and I have a long interest in diabetes, and I've been involved with a number of projects over the years. And I also work in community pharmacy. So my topic is insulin-related risks and medication safety incidents. I mean, as we all know, insulin is related to both safety issues like hypoglycemia and hyperglycemia, and we're seeing more and more people moving to insulin. Okay, so let's get my progression here. Okay, so where do we get our information in terms of medication safety incidents? Jerry alluded to it earlier on in terms of the number of medication incidents in the Northwest and CHO1 being 1,500 in 2.5 years. But all this information is collected from the National Incident Management System. This follows everything from start to finish, from reporting to management of claims. In particular, we're interested in medication, but just an important point on this is the fact that the NIMS system covers hospitals, community nursing units, ambulance service, CHOs, but what it doesn't cover, which is really important and a big gap, is the community contractors like pharmacists and GPs. So incidents that happen there, and that's obviously the vast majority of prescribings, are not regularly picked up.
Sorry, Trevor, can I interrupt you there? I'm just wondering, have you changed slides, because we're still seeing your title slide?
Okay, great. Right. Okay.
Yeah, that's changed now to the one that says NIMS, National Incident Management System. Thank you.
So yeah, I was just saying the coverage, NIMS covers the hospital sector, community nursing units, disability, right across to ambulance service, but doesn't cover GP practices and pharmacists. And then the information from NIMS is picked up and analysed by the state management, the state claims agency, and they analyse the incidents and do risk reviews, risk management, and look at education to manage these issues. So this was a report that came out in 2020 about the previous couple of years. And in terms of insulins, what is the level of issues? And this is some more up-to-date information. 52 incidents with insulin in Q1 2021. But going back to 20...
Sorry, again, Trevor, we're not seeing your slides move, unfortunately.
Now, let me see.
Sorry.
Yeah. Are we on insulin safety there?
No, we're still on the NIMS page.
Okay, right, okay.
Yeah, there's been a suggestion, Trevor, that I could maybe share your presentation.
Let me see now.
If we're having a problem with the connection.
How are we there now? Can you see that?
I see nothing just yet, no.
Okay, I'll go back to, apologies for this.
That's okay, it's WebEx or it's online stuff. This sort of stuff does happen, Trevor, so I just ask our attendees to bear with us.
Can we see that there now?
We have the NIMS page up now.
Okay, and are we moving there?
We just saw your desktop.
Okay, right, yeah.
Yes, state claims agency. Okay.
Yeah. So I'm here on. Yeah. Okay. So I talked about the level of incidents with in the area. 20,000 incidents in 2017 and 18 nationwide, and insulin is the fourth most commonly indicated pharmacological subgroup. And then insulin aspartate, which is your Nova Rapid Nova Mix, with the 6th most common implicated medication by generic name. And then just some data from across the water. In the UK, 40% of hospital inpatients in an audit in 2019 experienced insulin dosage errors. So there's quite a level of risk and harm with insulins. So okay. So can we see that there now? Yeah. Okay. So there we are. As we had from an earlier presentation, antithrombotics are the #1 pharmacological category, but insulins and their analogs are their #4. So are we seeing the presentation there? Yeah. Safety issues.
Yes, Trevor, thank you.
Yeah. Okay. So these are the 4 areas I'm just going to talk about today. Not in any particular order of importance, but we have high strength insulins, the risk of dose errors associated with extracting them from cartridges and pens, the risk of cross-contamination with insulin preparations, and finally, which would be the bigger area, would be prescribing and dispensing errors. So I just bring your attention to the Irish Medicine Safety Network, who produce a lot of very, very good information and alerts about high-risk meds. And this is one they brought out about the high-strength insulin preparations. Up until very recently, all of our insulins were standard strength of 100 units per mil, which made things pretty straightforward. You could give a dose by volume. But in the last number of years, we've had Tresiba, Humalog, Toujeo, which go up to 300 units per mil. So dosage errors around these obviously can have a huge, huge effect. One other little point here is that insulins are not interchangeable. Lantus and Toujeo both contain insulin glargine, but they're not bioequivalent. So you can't just use one instead of the other and reduce the amount of dose. They're not bioequivalent. So the recommendations from the Irish Medicine Safety Network on the high-strength insulins is always to prescribe them by brand name and by strength, and always to write units rather than use any abbreviations like U or IU, because these can be confused with digits in terms of a dose. And in the case of Tresiba, to circle the actual dose, or Tresiba 100, Tresiba 200. With safe supply, storage and labeling, it's important to have on a named patient basis. Select the correct product by name and by strength, where multiple strengths exist. And especially in a hospital setting or on a ward, you should make sure that you have enough of the actual volume of pen for the doses that are going to be administered within the time frame. For safe administration, check the brand and the strength of the insulin preparation, and only administer using the pen device with appropriate needle attached. Visually verify the dial units on the dose counter of the pen against the units prescribed. A couple of patient factors. Tresiba, in order to self-inject, patients should be able to should have good vision, because if they don't and they're relying on, say, audible prompts, then they could click up by what they think is 1 unit, but like Tresiba 200 isn't, you increase by every click is 2 units. So Tresiba wouldn't be suitable for somebody with visual impairment. This was a case that happened in the UK, just about extracting insulin from a cartridge or from a pen and using an insulin syringe. This lady, Kathleen, she had type 2 diabetes. She just went in for a routine for a reason completely unrelated to her diabetes. She was on this really high Humulin or 500, which is obviously 5 times the strength of most insulins. And And what happened was the nurse extracted the insulin with an insulin pen, an insulin syringe, and the patient got a 5 times overdose. So that's very much a no-no, not to do any sort of extraction. The risk of cross-contamination with insulin preparations. You've got your pens and you've got your replaceable needles, but studies, there have been a number of studies to show that whenever you inject insulin, that there's traces of squamous and epithelial cells in the needles and the cartridges following injection in almost 2/3 of cases. And another study showed that in 4% of cases, there were traces of regurgitated blood in the cartridges. And this is such a big problem, especially in probably third world countries, where the WHO reckons that there's what they call a silent epidemic of unsafe injection practice. And this is a major contributor to the spread of diseases like HIV, hepatitis. So the lesson here is that safe administration, one person, one pen, even if the needle is changed, that's very much a no-no. Just one person, one pen. And finally, the fourth area I wanted to look at was insulin products with similar sounding names, because these are the ones that we have errors in practice between prescribing and dispensing. And you can see a list of them there. It's not an exhaustive list. For instance, there's all the T's. You have your Tresiba, 2JO, and this is got even more complex because they're now injectable GLP-1s, and you now have the likes of Trulicity, and you can see there's other drugs like Ozempic used for weight loss. So there are a lot more injectable products that patients are taking. So it's really important to be very careful about these and to put up your list of salads in your practice so that you're always aware of the possible chances of a mix-up. Now, of these, the ones that I think actually the HPRA should do something about is the Humalogs and Humulins, because I think they're very badly named, and I have a number of cases of mix-ups. So I'm going to give you a couple of cases that I've come across. Now, these would be through general practice, as in like through GPs, pharmacists, ones that wouldn't be picked up by the NIM system. And these have been brought to my attention through some of the diabetes nurse specialists I work with. So in case one, a patient was prescribed 40 units of Humulin M3, a long-acting insulin. The patient dispensed Humalog, which the pharmacies already dispense Humalog, a fast-acting insulin in error. The patient now noticed that the insulin was clear, which was unusual, and then noticed that their blood sugars were quite erratic, and they prompted them to check their insulin pen where they discovered the error. Because the Humulin M3 is a suspension, so it should be quite cloudy. And this also brings the point that it's very important that patients are very familiar with their insulin, so they know what they look like. So if there is anything strange, that they're alert and can check it before they come to any harm. And this is just a little excerpt from the insulin preparation charts produced by Sligo University Hospital by the diabetes nurse specialist there. This is an excellent poster giving clear visuals on the different products, the pens, and also the profile. And just for the previous case there of the Humalog versus the Humulin, you can see that with the Humalog on the right, the profile is very short acting. You get a spike and a max within 1 to 3 hours, whereas with the Humulin M3, it's a biphasic with maximum effect between 2 and 8 hours. So that's why the patient would have experienced hypos and erratic blood levels. The second case was brought to my attention by a diabetes specialist who was doing a teleconsult with a patient. They were taking Humulin M3. That one we're looking at, the biphasic one, but they had unresolved postprandial hyperglycemia, and it seemed to be that the insulin wasn't actually working, and the strict dietary measures were put in place, but it still didn't seem to be working. So the nurse asked the client just check your pen there, the color of it and the name on it. Discover it was Humulin I, which was a different insulin. It's a quicker insulin. It's not biphasic, so you wouldn't be getting your postprandial peak. And what happened in this case was that the GMS prescription was initiated in, say, July 2018, and was, say, brought into the pharmacy. But what happened then was the pharmacy was working off the client's LTI book, their long-term illness book, which had the old record of Humulin I, and therefore the error occurred. Now, I mean, the good thing is that this type of error, case 2, is less likely to happen going forward, because the PCRS no longer issue LTI books for new patients. They issue cards because it's really just an eligibility function, and there's no longer an LTI book to be a repository for prescriptions. And of course, with the advent of healthmail during COVID, these are the records that pharmacists and GPs will be using, rather than putting anything into an LTI book. So, like, nurses, GPs shouldn't really be seeing, pharmacists shouldn't be seeing LTI books anymore. So those are just some of the instances I've come across, but there is a huge gap as to what happens in practice. And the important thing is to recognize the errors occur. What can health professionals do? Well, the very important thing is to record safety incidents. I go into community pharmacies. I don't go into GP surgeries or into see practice nurses, but I always check the error and incident log, because if you tell me that the last 6 months you've had no incidents, that's not true, because incidents happen, mistakes are made. But the really important thing is that we identify what contributed towards those incidents, and to put measures in place so that they don't reoccur. Is it staff training? Is it moving the medication around in the pharmacy? And this would be the same for all the healthcare professionals. And there should be regular safety meetings to educate all members on the healthcare professionals. Another really important step all health professionals can do is to share the Irish Medicine Safety Network best practice alerts. I mentioned the early one about the high strength insulins. Display insulin charts and salads for easy reference. I mentioned the Sligo University Hospital insulin charts. That's in the progress. The process of being reviewed, and it will be out in the near future. And we can email that to any of the healthcare professionals and use it as a good reference, visual reference. Probably less known aspect would be with no check ask, looking at medication lists. We're all the time trying to encourage patients to keep a medication list. But if a pharmacist is checking the most recent medication for a patient, the insulin could be well down the chart. It could be maybe 5 or 6 months ago, because if you're on a basal insulin and you're maybe taking it 10 units per day, it could take you 4 or 5 months to go through a box of your basal insulin. So it may not appear. So it's important to put that in. And finally, I would say include insulin dosages on your prescriptions and your PMRs. Now, I have a star there because a lot of patients, especially if they're type 1 and they're doing carbo measuring, and they match their insulin dose versus their carbos, they will be changing all the time. But I'm talking about probably more like type 2 patients, and especially as we have a lot of patients with cognitive issues, confusion, it's important that we reaffirm what dose they are taking and if they're at risk. So that's just a whistle-stop tour through insulin, the risks, and medication incidents. So thank you very much for listening. These are some really, really good useful resources. I say the Irish Medicine Safety Network. Most health professionals will get information from the HPRA about alerts. And yes, so thank you for listening, and thanks to Colin for organising this and putting it all together, and to the whole D&T team.
Great, Trevor. Thank you very much indeed. And Trevor, you're bang on time.